Hello, I'm Ulrika Wolf. I'm a clinical hypnotherapist and strategic psychotherapist based in New South Wales, working with clients by telehealth across Australia and, where appropriate, internationally as well. This briefing is about scope of practice, suitability, referral, and collaborative care. For health practitioners, I find that they are often interested not just in whether a referral is appropriate, but also what happens after the referral is made. You may want to remain actively involved in the client's care, receive relevant updates, and coordinate around a specific treatment goal. Alternatively, you may prefer to refer the person to me and then step back unless further information, consultation, or clinical input is required. Both approaches can work. My aim is to make the referral process clear, proportionate, and practical, while ensuring the client understands who is responsible for each aspect of their care. Health professionals may refer patients to my service. Once a person is accepted into my practice, I use the term client to describe the person receiving clinical hypnotherapy or strategic psychotherapy. My role is to provide focused, therapeutic support using strategic psychotherapy and, where clinically appropriate, clinical hypnosis. My work is process focused. I'm interested in not only what the client is experiencing, but in what happens when the difficulty becomes active and what maintains the difficulty. That may include where their attention goes, what they predict, how they interpret what's happening, what they do internally or behaviorally, and whether those responses may actually be unintentionally contributing to the difficulty continuing. The work then focuses on helping the client understand, rehearse, and practice a more useful response. Clinical hypnosis may support that process through focused attention, imagery, suggestion, mental rehearsal, or structured self-practice. It's one possible method within a broader therapeutic strategy, and it's not automatically used in every session, and I don't present it as the only option they have, as a cure or as a standalone approach. Within my qualifications, training, and competence, my work may include strategic psychotherapy, clinical hypnotherapy, process-focused assessment, collaborative formulation, therapeutic education or psychoeducation, guided imagery, rehearsal, skills development, and agreed between session practice. I generally work best where there's a reasonably clear concern or therapeutic goal that the client or the referrer comes to me with, and where there's an active, focused, and experiential approach to it, and where that would also be appropriate. For example, the work may involve helping a client rehearse a different response to performance pressure, work with patterns of avoidance, rumination, or self-focused attention, support behavioral change alongside appropriate medical care, develop more effective self-regulation, or respond differently to symptoms associated with an established condition. My work may be adjunctive as well. That means that it can sit alongside care provided by a GP, psychologist, psychiatrist, medical specialist, physiotherapist, dietitian, pain service, or another allied health practitioner. In some cases, the therapeutic goal may be very specific. A practitioner may continue to manage the primary diagnosis, medication, rehabilitation, or broader treatment plan, while I work with the client on a defined behavioral, attentional, or self-regulation target in that active, experiential way. It's equally important to be clear then as well about what sits outside of my role. I don't provide medical or psychiatric diagnosis, medical investigation, prescribing, medication management, emergency assessment, crisis intervention, inpatient treatment, forensic assessment, or expert evidence. All of those are outside my scope. I do not advise clients to stop prescribed medication or discontinue necessary medical, psychiatric, or psychological care. Concerns about medication are referred back to the prescriber. I also do not use hypnosis to search for allegedly repressed memories or to establish whether uncertain memory is historically accurate. A diagnosis alone, as well, does not always determine whether someone is suitable or unsuitable for clinical hypnosis or strategic psychotherapy. Suitability depends on the person's current presentation, stability, level of risk, treatment goals, capacity to provide informed consent, the proposed intervention, and the supports already in place. My own practice does, however, have defined boundaries. I do not provide treatment for epilepsy, psychotic disorders, schizophrenia, psychosis, bipolar disorder, or primary depressive disorders. I also do not provide crisis intervention, emergency mental health care, or management of acute suicide or self-harm risk. This does not mean that every person with a complex diagnosis is unsuitable for every form of hypnosis or psychotherapy. At this stage, it means that those presentations fall outside the service that I provide and may require treatment from a practitioner with appropriate specialist registration, resources, and level of clinical support. Routine clinical hypnosis and strategic psychotherapy are also not generally emergency or crisis services. Urgent medical, psychiatric, or crisis assessment is required where there is an immediate or serious risk of suicide or self-harm, serious risk of harm to another person, acute psychosis, delirium, severe confusion, acute mania, severe intoxication or withdrawal, or another medical or psychiatric emergency. In those circumstances, focused outpatient therapy is not the appropriate first response. My practice is not continuously monitored and should not be used as a crisis contact point. There are also situations that may not be immediate emergencies but still require further assessment or specialist involvement before therapy proceeds. These may include impaired reality testing, substantial dissociation, diagnostic uncertainty, significant instability, complex medical or psychiatric comorbidity, previous destabilization during imagery or experiential work, or symptoms that require medical investigation. In those cases, the response may be to seek further information, recommend medical review, coordinate with an existing practitioner, modify the proposed work, pause treatment, or refer elsewhere. Pausing or declining treatment is never a judgment of the client. It's a decision about safety, treatment fit, scope, and setting. Psychotherapy should not be used to assume that unexplained physical symptoms are psychological. That's the same for clinical hypnosis. Medical assessment may be appropriate before or alongside therapy where there is new or unexplained pain, or if they've got significant gastrointestinal symptoms, substantial sleep disturbances, sudden changes in mood or cognition, neurological symptoms, unexplained weight change, medication-related concerns, or possible substance withdrawal. The purpose of medical assessment is not to exclude psychological support, it's just to ensure that the relevant medical contributors are not overlooked and therapeutic support is properly positioned, and we're not overclaiming what clinical hypnosis and psychotherapy can do for a client. A formal referral is also not generally required for a private appointment. A person may contact me directly or be encouraged to do so by a health professional. A written referral can still be very useful, particularly where there is relevant medical or psychiatric history, current medication, diagnostic uncertainty, recent investigation, known safety considerations, existing specialist care, or a defined adjunctive treatment goal. Helpful information may include the reason for the referral, the main concern, the intended therapeutic goal, relevant diagnoses, current medication, current treatment, previous treatment responses, and any known precautions. A referral does not automatically guarantee that treatment will proceed either. I complete my own assessment and remain responsible for deciding whether the service I provide is appropriate and within scope once I assess all the factors. The level of referrer involvement can also be tailored to the situation. Some practitioners prefer active collaboration, That may involve clarifying the referral goal, sharing relevant history, receiving a brief update, or discussing whether treatment should continue, or pause or change. Others may prefer a more hands-off referral. In that case, the practitioner may provide the initial information or recommend the client to contact me directly and remain available only if further input is required. That is also appropriate, provided that the client understands the arrangement and there's a clear pathway back to the treating practitioner if medical, psychiatric, or specialist review becomes necessary. My involvement does not transfer responsibility for diagnosis, medication, or treatment outside my scope. Likewise, the referrer does not become responsible for the therapeutic decisions I make within my own service. Each practitioner remains accountable for the care they personally provide. A referral does not provide unrestricted permission to share information either. Communication occurs with the client's knowledge and the appropriate consent. Depending on the purpose of the referral, I may communicate whether the client attended, whether treatment was accepted, the broad therapeutic focus, whether hypnosis forms part of the plan, the progress relevant to the coordinated care, concerns suggesting further review, or whether the treatment has concluded. I would not ordinarily provide a verbatim account of sessions, every personal disclosure from the client, or detailed psychotherapy process notes. Communication should be relevant, proportionate, and connected to the purpose of care and within the client's consent. After a referral or inquiry, the first step is an assessment. That assessment considers what the client wants help with, their current presentation, relevant history, medication, risk, stability, capacity to consent, whether hypnosis is relevant, whether telehealth is appropriate, and whether another practitioner should remain involved. Possible outcomes include proceeding with a defined therapeutic focus, seeking further information, recommending medical or specialist assessment first, modifying the proposed treatment, referring the client elsewhere, or declining treatment where it would not be responsible to proceed. Where treatment proceeds, we agree on the therapeutic focus, the proposed approach, the possible role of hypnosis, expectations for participation, and any between-session practice. How progress will be reviewed and whether communication with another practitioner would be useful is also discussed. Suitability can also change during treatment. If the presentation from the client changes, risk increases, or the work is no longer appropriate, treatment may need to be modified, paused, transferred, or discontinued. For me, collaborative care begins with clarity. Clarity about what the client needs, clarity about what I can provide within scope, clarity about which practitioner remains responsible for each aspect of care, and clarity about when focused therapeutic work is appropriate and when another level of care is required. My role is to provide clinical hypnosis and strategic psychotherapy safely, ethically, and within my qualifications, training, and competence. That includes being willing to collaborate closely where that is helpful, while also making the process straightforward for practitioners who prefer to refer and remain hands-off unless further input is needed. Thank you for taking the time to learn more about my scope of work and how we may work collaboratively. You can read the complete briefing through the online hypnotherapist Clinical Briefings Hub.
The Clinical Briefings Hub is a free, dedicated professional resource for GPs, specialists, and allied health practitioners who would like more detailed information about clinical hypnotherapy, strategic psychotherapy, and referral considerations. The Clinical Briefings Hub is a separate space that allows you to explore the complete evidence-informed briefings behind the information on the main website. When you open a briefing, you will see the estimated reading time at the top so you can decide whether to read it now or later. Each briefing also includes call-out summaries that highlight important clinical points and practical information for quick review. The content is divided into clear sections, allowing you to move to the information that is most relevant to you. You can also expand or collapse sections as needed and skip to the sections that are of most interest. You can also review the supporting sources in the footnotes and click directly through to available research, professional guidance, and further reading. The complete briefings include all three collections: foundations, clinical, presentations, and the referral process. And you can see there's far more here as well for you to access. Health practitioners can freely access the clinical briefings by subscribing to the Online Hypnotherapist professional updates.